So next up, again, another piece of the puzzle that all of us face when it comes to introducing new things, new treatments, new intervention is training. Training for our staff who are tobacco dependency or stop smoking advisors, training for healthcare workers if you're working in the NHS, training for others. And of course, the NTSCT, this is their forte. They've been doing training in this area for decades now. And I'm very pleased to introduce both Sophia Papadakis and Louise Ross to talk about the training and resources available through the NTSCT. So Sophia, over to you.
Good afternoon, everyone. I've really enjoyed the talk so far. So great to see the lessons learned and the challenges being faced together. Let's talk for a few moments about training and what's available, in addition to training resources. We now have our suite of first-line tobacco dependence treatments, and front and center there, figuring in there, are our nicotine analogs, Varenicline and cytisine. A reminder that these medications work on their own, but when combined with behavioral support by a trained healthcare professional, or in the case of community stop smoking advisor, they work even better. And it's been said earlier, I think almost everyone in their presentation echoed this, the importance of making sure that our patients, our community members have access to the best available treatments, and that be done equally across the country with the great work happening. To signpost to a few resources that have been published very recently and some that have been around for a while but have been updated, we wanted to talk a little bit about the local stop smoking services support commissioning, service delivery, and monitoring guidance. In that document with the web link that's here, that was published, updated, it's the 10-year update this past March, you will find a number of evidence-based summaries. So if you're looking to, as Matt spoke earlier, make sure you've got easy access to the latest evidence and position. If you're in community, likewise, for commissioning purposes, this document is your go-to. The link is there. Everything we spoke about this morning in previous presentations as it relates to why we're introducing this treatment and what the urgency is around it is summarized in that document. This is a summary from there that's pulled from the Cochrane review that Matt referenced earlier. And I want to remind us, as we think about it, also in this document are the behavior change techniques that we use in both inpatient, outpatient, and community settings as it relates to supporting our residents who smoke with stopping. One of those behavior change techniques that are around this circle is advising on stop smoking medications. It's one of several things we do to help individuals quit, but we know it bears a significant weight on their ability to quit successfully. It is a behavior change technique because we can prescribe the medication, but in addition to that, we want a workforce of healthcare professionals that knows how to advise on the correct use of that medications. And so increasing prescribing confidence, but also throughout the course of using that medication, discussing those medications, that we all feel really comfortable with how to do that well, and what are some of the nuances around using these medications. So on the screen here are some of those nuances, if you will. Spoken to earlier is making sure that people understand what their options are, what might be best suited to their needs. We know our nicotine analogs for more heavily dependent individuals, those with past use of one of the other therapies, may benefit from using Varenicline or cytisine on this next attempt. Having realistic expectations around the medications as well is one of the jobs that we need to make sure we are doing well. Providing proper instruction around its use and how we deal with some of the side effects so that you are informed, but also many of the side effects that are experienced with our nicotine analogs can be well managed with a couple of quick techniques. So making sure all of our field of workforce are aware of that and can help people stay on these medications should there be some of these common side effects experienced. They don't occur with great frequency. When they do, we've got strategies. Using enough for long enough, so when we need to extend doses, and as well making sure we can adjust treatments as needed going forward. This is really what the training that we're going to be talking about seeks to make sure the field is ready to address. So a little on the training resources that you can access today, and in particular access from the NCST website. These are training resources that almost everyone on the call that have already spoken have contributed to developing, as well as many other experts across the country. They happen to be held right now on the NCST website, and you'll find them by looking up under guidance, stop smoking medications. So there's a tab there with a drop-down menu, and all of the medications are listed there, but in particular, Varenicline and cytisine, you can quickly identify training and resources that are there. A little known tool that's hiding there and might be useful is our quick reference sheet, of which a screenshot is available here. And earlier this year, cytisine was added to that. That's one of those quick references that all clinicians who are either prescribing or supporting use of the medications may want to know about. It means we don't need to remember everything right away as something new is introduced to field, and it's the kind of laminated sheet that some individuals might benefit from. We have a number of e-learning courses, some directed to the inpatient setting, some directed to community setting, and all have been updated to reflect the availability of varenicline and cytisine and the education we all need as a workforce to be up to date on these medicines and how they're used. A reminder that the NCST has an e-learning platform that is available across the UK in all countries, that it's free. You do need to register, open an account, and that's about it. You are ready to go and you'll be able to access a suite of e-learning, one of which is our Stop Smoking Medications module. If you've done that training before but want to see again the varenicline and cytisine sections, you can do just that. You can go directly to that section of the e-learning and access that. Likewise, our Stop Smoking Practitioner training, the National Certification of Stop Smoking Advisors, has been updated to include cytisine. It has always included varenicline, and there you'll be able to see in both training videos of how we explain the medications, what we do when we experience side effects, and any practical details that can support clinicians with the skill of an art and science of speaking to patients and community members about the medications. There is also an inpatient e-learning. It's being launched in the days ahead. I don't have a final date for you, but it also includes a module, again, on stop smoking medications where for our NHS colleagues, that will be available to you and at your fingertips. Here are some screenshots from the training, and you can see there are a number of film clips that demonstrate conversations with patients and community members. And here's a screenshot of the e-learning with a link to that for NHS. In addition to e-learning, I want to let you know that there is a PowerPoint deck that can be downloaded from the NCST website that includes our nicotine analogs. So from everything about why we use them, how they're used, their mechanism of action, in high quality slides. This is an NHS NCST partnership that allowed for these slides to be developed, but they can be downloaded from the website for, if you will, internal meetings, education events, and they're short, sweet decks that get to the point around prescribing in some of the key issues. Some screenshots here. There is also a briefing on cytisine, a newly published briefing. Several weeks ago, it was announced, and that can be accessed via this link. Provides you dosing guidance and other key pieces of information. So to signpost you to that, I think is all we want to do. In addition, there is a short, very short film that talks about cytisine, really just to help introduce it to the field and the workforce. You can see the speakers that are here, but to let you know that that's there, and again, can be accessed via the Stop Smoking Medications tab of the website. So I'll stop there, and just two final slides. I'll turn over to Louise Ross to say a few words. Louise?
Thanks, Sophia. That was so good. Yeah, and I'm very aware while we've been talking and reading the chat along the sidebar, just how many services are experiencing frustration about needing to get cytisine and varenicline onto their local formularies. And you know, this is something totally would happen just now, wouldn't it? Dog barking. It's something that we get requests for information about all the time from not only stop smoking services, but from patients as well, saying, you know, I'm desperate to get hold of some cytisine. How do I do it? Because my GP sends me to the stop smoking service. They say they can't prescribe it. And so the patient is going backwards and forwards. And my advice would be, get somebody really senior in your organisation. This is to Stop Smoking Services. Get somebody senior in your organisation to start getting onto the medicines management team of the ICB and say, you know, this is a priority, because it clearly hasn't been made a priority in many areas. You know, they're probably dealing with other really important stuff, but for your patients, for your clients, for your people who smoke in your area, they need another choice. Nobody is going to do that for you, and you know, this is very clear that, you know, when you've got somebody like Joanna Feeney on your side, you know, working day and night to get availability of these new medications, that's great, but it's a lot of work, and somebody needs to take responsibility for that in your local area. Otherwise, people will just carry on smoking because the choice that they would have made isn't available. Can you slip to the next slide, please, Sophia? Thank you. Because we know that most people who smoke are looking for some magic solution. They think that this next thing, this new thing, will be the thing that works. We know that there is no magic, but we can inspire people to put their trust in the treatment plan that is going to be devised for them. Important as well to ask each service user or client for some honest feedback about how this worked for them. We need to know, you know, did it work? Try and get them to come back at the end of their quits to say how it felt, the side effects, you know, any difficulties that they had, the dosing regime, for instance, because we can use those lessons to increase the confidence that we instill in our clients going forward. Thank you.
Great, that was it from us.
Great, thanks very much. So I'd like to thank all of our speakers. I think we've had a lovely canter through a variety of areas, from Matt in Manchester and the team in Manchester doing the fabulous work with the various NHS trusts there, and the regional permissions that they've worked on. We then had Kieran with the work that the specialist pharmacy service has done to try and make it easier for everybody to and produce a template for a national PGD for Varenicline and one on cytisine coming soon. The amazing work that Joanna's done with Fresh and Balance in the Northeast. And I think that, Joanna, that's a real model that lots of regional groups could do to support local government services. I know in the Midlands we've got, I think, 25 local government services, and it would be great if we could sort of do once and share with the same model and learn from you. And I'm sure you'll, you know, it's similar in London, for example, and in other regions too. And then, of course, last but not least, Sophia and Louise and all the amazing training resources. Lots and lots of information for people to take in. I know that Ash are planning to share a link of the recording and other resources on their website. I know that people have been answering questions as we go along in the chat. We've got another 15 minutes for chat. But I think what I'll do is, while people come in with questions, and Claire, I don't know if you can help out with questions that you've spotted that we've not yet answered.
So I posted a list of questions in the chat, so ones that we've picked out that haven't been answered just by our speakers or by other attendees, if you'd like to pick them out. There's 10 of them so far. Okay, so maybe I will pose them then. So I understand neither medication is suitable for the under 18s. Can you speak as to why? Well, I think that would be purely because of the way the clinical trials were done. Generally, these medications are only trialed in adults. That's not to say that they couldn't be used, but they would have to be used off license in people who are younger than that. I know cytisine, for example, shouldn't be used in people who are over 65, but we do use them off license in people who are older than 65. And it's really to do with how trials are put together and the funders for the trial that we often have these types of exclusions. So question 2, does it also cover community stop smoking services? I believe there is a barrier for community stop smoking teams that they have a band 4 advisor who can prescribe NRT, but the two drugs have no professionals who are qualified. So I think that's to do with
PGDs, Kieran, that's probably one for you. And with NRT, my understanding is because you can get it over the counter, PGDs, you could use PGDs to provide NRT on wards and other non-professional groups. But yeah, I'll leave it to you, Kieran, to answer that one.
Yeah, so non-registered staff can supply rather than prescribe NRT because it is a general sales list medicine. So it's not under a PGD, it's under a protocol or a trust-based or local authority-based policy. And yes, PGDs have to be used for prescription-only medicines. They're enshrined within legislation and it can only be a registered healthcare professional who can work under those. So policies and protocols have no legislative footing, so it's a free-for-all.
Yeah. I mean, I think, Joanna, you tried to address this with some of the work that you were doing, weren't you? Do you want to speak to that? So local authorities using a regional PGD, you seem to be cracking that one.
Yeah, so I mean, obviously, within the PGD, you do have to be a registered healthcare professional in order to utilise it. And in our stop smoking services, as I say, there's 12 different types of services, different models. Some of them do have registered nurses. Some of them have a couple of nurse prescribers. But what we wanted to do is we wanted to make it equitable across the board. So it doesn't matter how the service is delivered, the band of the advisor, whether it's delivered outreach, specialist service, which was the reason that we came up with the pharmacy supply PGD model. So it was working with our colleagues in community pharmacy as the pharmacists being the registered clinician there.
And I think that's a great model, actually, and it'd be great if we could unlock that at a national level too. Matt, I think questions 3, 4, and 5 are for you. I don't know if you can pick them up in the chat.
Yeah, I can. So, Varenicline with NRT, offer your stance of use, but concurrently in the efficacy of it, as both work differently. So, I think it's just the specific scenario of an inpatient setting. That's where it feels so useful. So an outpatient setting, that person continues to smoke, and as Varenicline's reaching its maximal effect, the smoking should come down. And so Varenicline is ideally by day 14 that they set a date to stop, though it can be, some people need longer than that. Cytisine's day 5, but there is an initial period where acknowledging that it's likely additional nicotine is needed. But in a smoke-free environment, in the inpatient setting, that has to be from an alternative source. So I think it's why the BTS statement is designed exactly as it is. It really states the importance of how rapidly we need to get people onto combination NRT to mitigate withdrawal from the very moment of admission. Most will be withdrawing and suffering from withdrawal at the point of admission or very, very soon afterwards. And NRT is so readily available, we get that prescribed in combination as soon as possible. But the data, everything we've heard today about how effective Varenicline and cytisine is beyond that of NRT. So offering those all the patients we meet the opportunity to access those treatments is the right thing, and for those where it is right and it is appropriate, we start that in addition to the NRT. So it's more, I think it's just that unique scenario being in a smoke-free environment in a hospital setting. The two things just work well together.
Can I just come in there, Matt? And also we do have efficacy data from local government stop smoking services that demonstrate the combination therapy of NRT plus either e-cigarettes or Varenicline are actually more effective than each of them on their own. So there is efficacy data as well.
May I jump in just to say?
Yeah, go on,
may I jump in
please.
just to say
Yeah.
that if anyone's looking for a summary of that, both the BTS guidance and the local stop smoking service guidance have a section where we provide references and a good solid summary of what we know and don't know about combining the nicotine analogs with NRT.
Great, thanks, Matt. The next one is also, I think, for you. How is the prescription titration of the course managed once a patient has been discharged from the hospital setting? So I suppose this is about follow-up. So how do you guys do it in Manchester?
So it's such a well-described prescribing regimen So Varenicline comes in an initiation pack of the 14 days. It's got the first week of titration, and then that person's on to the 1 milligram BD, all within that initiation pack. So 14 days of that, and then they've got a maintenance pack for the rest of the 10 weeks. So we do, as we would with any other medication, education with a patient, supportive information and patient information leaflets. We've heard lots of good resources today that go through those regimens. Cytisine is the same, it's a bit more complicated, but the NCSCT have got a really nice diagram that we use. I think everybody uses it, of the 6 down to 2 tablets, where patients can actually tick off by the days. So it's never really been a barrier of a patient not being certain or sure how to use it. I think it's relatively straightforward. And the follow-up, because because we're providing the full courses, it's then so suited to telephone support and follow-up beyond, where you can provide the behavioural support alongside it. And we can check in on how things are going with the medications.
Brilliant, thanks. Matt, right, and then there's a question about funding. Just very briefly, Matt, do you want to come in, because then we'll also try and get to some of the others as well.
Yeah, so it's within the trust funding. As I said, I've really tried to highlight the point of the cost-saving element to it. We're already providing treatment courses, and that it's been cost-saving against those.
Brilliant, thank you, Matt. Kieran, I think you've got the next question, and it's sort of saying, I think, why is the PGD for Varenicline so kind of focused on monitoring various other drugs if people stop smoking with Varenicline, whereas we don't have these same requirements for NRT, it would seem?
So there's lots of published evidence which suggests that metabolism of a range of medicines is affected by stopping smoking. And some of these are quite serious, so clozapine being the most high risk. And there are others where there is huge interpatient variability. So one patient may develop side effects, but the next patient may not. We were really aware that developing this national PGD template, we didn't want to rewrite national policy on this. And we wanted to highlight to people that there may be a risk with some of these medicines, especially those with a narrow therapeutic index. So it's to kind of make people aware again of the importance of just counseling patients of the risk of side effects and looping back in with their stop smoking services, who then may need to contact a GP or prescriber to amend the dose. So we are aware that in lots of services with NRT that it doesn't happen, but that doesn't mean that it doesn't happen with patients, and they may, we just want it to be as safe as possible.
Okay. I think the question was about the disparity between stopping smoking by some other means versus Varenicline. And
it should be the same.
It should be the same, but it wasn't actually. And then I suppose there's another question for you. The safety of Varenicline in pregnant women. I mean, I think we can't really do much about that. If it's been excluded based on the trial, there's not much more to say about that, really. It's a contraindication. I'm rattling through the questions here just because I know we've only got a few minutes there. Sophia, if you wanted to come in on one of these points.
Would that be okay? I just wanted to echo what Kieran has said, but maybe a point of clarification, because for everyone on the line, it is not these medications that causes that interaction, is the tar in smoking, because we often get that confused. And I think when it's inside of a PDG, it can be even more confusing. So the medication interactions that Kieran just spoke about in the questions relating to that, in particular psychotropic medications, is not related to Varenicline, cytisine, or NRTs, but rather stopping smoking. So I just want to make sure we don't again lose sight of that important fact.
Yeah. Now, the next 3 questions, Joanna, are kind of, well, certainly 9 and 10 are, I think, related to the work that you were describing. And again, one's about antipsychotic dosing. So did you want to take question 9 and 10, and then maybe I can come back to question 8?
Yeah, sure. So, I mean, we had a lot of discussion in terms of, obviously, we are utilising the national PGD and recognising that there's only a few parts in the national PGD that you can actually amend. We've taken the decision to exclude patients who are on high-risk medications from the PGD, but we do include the medium-risk medications. with the PGD, what we are looking to build into the templates on farm outcomes is a flag, so an automatic email to go to GPs informing them that the person has been issued with the medication. If they're flagged as having one of the medium risk medications, this would be the same process as Stop Smoking Services do in their for any other quitters, nicotine replacement therapy. It will flag that they are on this medication, and it will ask that the GP, if they have any concerns, to contact the Stop Smoking Service within 7 days. So that's actually before they've actually stopped smoking, for example, with Varenicline. So it gives that bit of information there. One of the things we did talk with our, when we spoke with our primary care colleagues, was that, they felt that actually if it was somebody who was on was on, for example, clozapine, they weren't the experts in terms of the dose reduction. So it was needed to be very much a kind of a partnership approach, working with secondary care colleagues, mental health colleagues, and prescribers there as well. So I think, as I say, for us, we have used the national PGD. What we're trying to do is put some processes in place to make sure that no one is excluded completely. People on high risk medications won't get it the products through the PGD, but they can get it through through the close working relationships with the prescribers, whether that be primary care or secondary care mental health services. And then just in terms of the cost of the farm outcomes licenses, this was one of the reasons why our proposal included working with colleagues within Pharmacy Services North East, because that would actually be as part of their contract management. So the cost is the equivalent of £50 per pharmacy to contract manage it, and that would include the licensing and would give so that local authorities don't need to build in and pay for a licensing for additional systems as well.
Brilliant. John, I'm going to try and pick up the last couple of questions. There's quite a lot, though. The one question is about GPs, and there doesn't seem to be an equitable service provided by GPs, and I think Louise touched on this as well. And so some GPs will provide prescriptions for local government stop smoking services, some won't. I think that's because the funding models for general practice are quite different. So, for example, for hospitals, and that's why I think the work that Joanna's doing with community pharmacists is to bypass GPs might be quite helpful. So that's something I suggest we would pursue. I know there was another colleague of mine from Northamptonshire who was looking at an online pharmacy option and contract that might also solve that problem for local government, whereby the local GPs do not feel able to provide. There's another question from Claire Mellon, my colleague in Leicester. It's not a planted question, but it was a genuine question. To be able to pull out data into the national reporting template on the use of cytisine and Varenicline, is there a SNOMED code for this? And I don't know if anybody knows that. Kieran, you're smiling. I'm hoping. I don't know if that's
I don't know. No.
No, yeah, okay. Maybe that's one that we can put in the Q&A and hopefully get an answer for, because that's to do with reporting back to NHS England and using the electronic systems to not have to manually input data on those patients who've received cytisine and Varenicline, and how can we do that? And then let's see, safety of medications and people performing undergoing rehab. I would say it might sound a bit flippant, but probably these medicines to help stop smoking are safer than continuing to smoke. So in general, the only people I don't maybe prescribe things like NRT2. In fact, there isn't really anybody I don't prescribe NRT2. So I would say that a lot of those BNF warnings are probably related to original trials rather than actual clinical importance. So I think I'm probably going to stop us there. We've just gone over. It's been a fantastic webinar. Thanks to all our speakers. Thanks for all the brilliant questions. Thanks for the team at ASH for putting it together. It feels like we're going to need another one of these at some point in the future. And I think speaking to the team at ASH, once cytisine becomes fully approved by NICE in February, maybe we can arrange for another webinar sometime after that. But thanks everybody for a brilliant webinar, really helpful.
Thanks, everyone. Bye-bye.
Thanks, bye.